Welcome to the Merit-Based Incentive Payment System Reporting and Audit Readiness Conference Call. My name is Jenny and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to Mona Matthews. You may begin.
Thank you, Jennifer. This is Mona Matthews, and I'm with Metastar in Wisconsin, and I'm a project specialist. In addition to me presenting today, Reed Haas, a program manager from Stratus Health, will also be presenting. During the presentation, if you do have some questions, you feel free to put those questions in the chat, and we will periodically stop and try to answer those questions. Lori will be monitoring those questions. So just a little bit about the Lake Superior Quality Innovation Network, or Lake Superior QUIN. We are 3 quality improvement organizations: MPRO in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin. We collaborate to improve the health care of Medicare consumers. We also share best practices to maximize efficiency. We always like to start our webinars out with a disclaimer that the information provided in this presentation is based on the latest information made available by the Centers for Medicare and Medicaid, or CMS, and is subject to change. CMS policies change, so we encourage you to review specific statutes and regulations that may apply to you for interpretation and updates. With that being said, I just review a few objectives for today. We will be describing the reporting options for Merit-Based Incentive Program System. We'll review some of the documentation recommendations to prepare for a potential audit, and just a little bit about an audit readiness tool. So I'm going to start out by giving a very high-level overview of the quality payment program. We have made a few assumptions with this presentation that you do have some basic knowledge of the quality payment program. If that is not true, and you need more assistance with more basics of the quality payment program, please feel free to reach out to the organization in your state. We are happy to help you with that. So to start with the high-level overview, there are 2 paths in the quality payment program. The first is the Advanced Alternative Payment Models, or APMs. This is where you can earn incentive payment for participating in an innovative payment model. The second path, the Merit-Based Incentive Payment System, is the path that most people will be following this first year. Clinicians that participate in traditional Medicare may earn a performance-based payment adjustment through MIPS. So within an advanced APM, it is a payment approach that gives added incentive payments to provide high-quality, cost-efficient care. APMs can apply to specific clinical conditions, a care episode, or a population. For clinicians not ready to participate in advanced APMs, the higher level of APMs is available. Advanced APMs are a subset of APMs. Practices earn more for taking on some risk related to their patients' outcomes. You may earn up to a 5% incentive payment by going a little further in improving care and taking on some risk. To note, the advanced APMs have both upside and downside risk for their participants. The second path is MIPS, and there are 4 categories within MIPS. The first is the quality category. The quality category replaces the Physician Quality Reporting System, or PQRS. The second is Improvement Activities, which is a new category. Third is Advancing Care Information, and this particular category replaces Meaningful Use. or the electronic health record incentive program. The third category is the cost category, which replaces the value-based modifier, or VBM. There is a maximum score, composite score of 100 within MIPS. It is made up by weighting each of these four categories. In MIPS, 60% of the weight for the MIPS composite score comes from the quality category, 15 from improvement activities, 25 for advancing care. And for this first year of the program, the cost category is weighted at 0. There are some different reporting options for MIPS. There you can file individual reporting, group reporting. There's also the option for CMS web interface, and that is optional for groups of 25 or more. This is the only thing that required registration prior to the reporting period, which will open up January 2nd. And then the last is the APMs here. Okay, so the mechanics for reporting, if you were hoping to sign on today, you signed up and you were hoping to hear and look at a portal for reporting, we hate to disappoint, but CMS has not released any of these mechanisms as of yet. So we will, once these are released, have some future office hours or webinars to go through that. So one of the things that we get a lot of, at least I do, I get a lot of questions on is MIPS participation status and how to find out. There were letters that went out to clinicians that indicated whether they needed to report to MIPS. However, there is a lookup tool at qpp.cms.gov where you can enter an NPI and then click on Check NPI, which many of you have probably seen this and used this to check your participation status for the various NPIs at your facility. With that being said, I did want to go through some examples of how this shows up and what you need to do for reporting. Now, you'll go to this website, and this is how the clinicians that are both individually and group eligible are going to look. So if you look on the left-hand side, it says they are included in MIPS, and that this clinician has exceeded the 30,000 and has provided for more than 100 patients at the practice. And then also, if they are reporting as a group, they would need to be included in a group report. The second example is an example where the clinician is exempt from MIPS, but if they file a group report, they would be included in the group because the group has exceeded the low volume threshold. The third example here is a clinician who is exempt from MIPS because they have billed less than 30,000 or have provided care for fewer than 100 patients. And they are also exempt as group because the group does not reach that low volume threshold. So individual reporting, just to talk a little bit about individual reporting, is based on taxpayer identification number, TIN NPI combination. Therefore, there are some clinicians who may be associated with multiple TINs and would need to report under each TIN NPI combination. One thing to note about individual reporting is if you are using claims-based submission for your quality measures, you must use individual reporting for MIPS. This is a bit of a confusion with some of the people that I've been working with that would like to maybe report via EHR or they would like to do a group report. But if you have chosen claims-based reporting for your quality measures, you must report individually. And clinicians, just to note, and you'll see this over in some of my other slides too, but I think it's really important to note that clinicians that are part of a group report may also submit individually. And we'll talk a little bit about why somebody might do that in some of my future slides coming up. So group reporting is a single TIN with 2 or more eligible clinicians included, and the group report must include at least 1 MIPS eligible clinician that meets the criteria for a MIPS eligible clinician. There are 3 types of MIPS exclusions: the new Medicare enrolled clinicians, the qualified participants, or QPs, and partial QPs within an advanced APM. And then also, as mentioned before, those clinicians who do not exceed the low volume threshold. So some of the group reporting basics, just to remind everyone, there's no registration process unless you're using that CMS web interface. So if you are thinking, kind of trying to decide whether to do individual or group reporting, it is not too late to do a group report. You did not have to register in advance. Group reports must include all eligible clinician types associated with the TIN, even if individually they do not exceed that low volume threshold, or if they're newly enrolled in Medicare. So they would need to include all eligible clinician types. Each clinician participating in MIPS via a group will receive a payment adjustment based on the group's performance. And also, groups can include non-eligible clinicians, i.e. like physical therapists, in their group report. The reason some organizations may choose to do this is if their non-eligible clinicians are high performers and they raise their score. And also, clinicians included in a group report may also report individually. And the reason a clinician would do that is if they themselves are a high performer and their organization is submitting a group report, they could also submit an individual report, and CMS will give them the higher of the 2 reports. So groups electing to submit data at the group level will have its performance assessed and scored across the TIN. It could include services furnished by individual NPIs within the TIN who are not required to participate in MIPS, so those non-eligible clinician types. An example here is excluded clinicians are part of the group and would be considered in the group score. Now, when it comes to the payment adjustment, new Medicare enrolled clinicians or partial QPs would be included in the reporting in a group MIPS report, but would not receive a MIPS payment adjustment. The same is true about eligible clinician types who do not exceed the low volume threshold, need to be included in the reporting, but would not receive a payment adjustment. So to illustrate this, I'm going to walk through a few scenarios. But first, before I do that, I'm just going to check with the chat and make sure there are not any questions or clarification I need to make. Lori was...
No, and I'm not seeing anything, any questions in chat at this time either, Mona.
Okay. Thanks, Lori. So the first scenario I have is a group of clinicians. There's 11 total eligible clinicians in this, clinician types in this group. None of the clinicians meet the low volume threshold individually. However, the TIN as a whole does meet the low volume. So I put kind of a snapshot here of what that would look like if you looked each of these clinicians up on the NPI lookup tool. The left side says if the clinician reports individually, they are exempt from MIPS. If the clinician reports as a group, they would be included in MIPS. So just to show this kind of in a diagram way, my first scenario, we have 11 total eligible clinician types. 0 of these eligible clinicians meet the low volume threshold. So their reporting option would be to do a group report with all 11 clinicians, and they would receive a group MIPS score. The clinicians would receive feedback to prepare for future years. However, none of these clinicians would be eligible for a payment adjustment. The reason for filing this group report would be to receive that feedback to prepare for the future years. The second scenario that I'll walk you through is the solo practitioner. And she is a MIPS eligible clinician type. At the individual level is included in MIPS because they have billed $30,000 or more, and also they have provided patient services for 100 patients at this practice or more. So they are included in MIPS at the individual as well as the group report. So we have one MIPS eligible clinician type. The clinician does exceed the low volume threshold, and the clinician would need to submit individually and receive an individual score. In this scenario, this clinician must submit to avoid a negative payment adjustment. And payment adjustment will be based on the MIPS score of this one eligible clinician. The third scenario is 8 MIPS eligible clinician types. 7 of these clinicians are below the low volume threshold, and 1 of the clinicians is above the low volume threshold. So when we look at this, this group actually has 2 different reporting options. If you have 1 eligible clinician out of the 8, you could report individually for the clinician that exceeds the low volume threshold and do nothing with the other 7. However, with the other option would be to do a group report, and that group report would need to include all 8 eligible clinician types. So just some comments. Only the eligible clinician that exceeds the low volume threshold will be eligible for a payment adjustment. So some of the considerations you might want to take in this case when you have only one clinician in your group that has to report is how would the clinicians that are below the low volume threshold affect the MIPS score? So if the clinicians below the low volume threshold raise the score, the group may want to consider doing a group report to get a higher MIPS score for that one eligible clinician, or a higher MIPS adjustment for that one clinician. So the fourth scenario is a scenario where we throw in an advanced APM. So this is a clinical practice that is part of an advanced APM. 28 of these eligible clinicians, they have a total of 28 eligible clinician types, and 15 of these are qualified participants or QPs in the APM. Now there is a lookup tool so that you can check your clinicians to see if they have reached QP status for this year. I put the link in here, and I think Lori will also put that in chat if you want to capture it that way. So 13 of the eligible clinicians in this group that's part of an APM are not QPs in the advanced APM, and 10 of these have exceeded the low volume threshold. So if we diagram this out, we have 28 total clinicians. On the far left side of this slide, you'll see that 15 QPs in the advanced APM would be part of a group report for the APM entity score. So that takes care of those 28. Then there are 13 of them that are not participating in the advanced APM and would need to be addressed through MIPS. So 10 of these clinicians exceed the low volume threshold, and 3 are below the low volume threshold. So like one of the previous examples I gave you, they have 2 reporting options. They could do individual reports for those clinicians, the 10 of them, that exceed the low volume threshold, or they could do a group report. Now that group report would need to include all 13 eligible clinician types. So some comments about this fourth scenario with the advanced APM. The QPs in the advanced APM will receive a score based on the advanced APM. Now, there are many of the advanced APMs, which are ACOs, include multiple organizations. So they would receive one score across everybody who's participating in that advanced APM. Clinicians within the TIN that are not part of the APM will need to report to MIPS, as I mentioned before. And clinicians that are part of the group, they also report individually, like many of the other scenarios, and CMS will assign the higher of the two scores to those individual clinicians. So the scenario 5 is a larger group with 45 eligible clinicians. 22 clinicians exceed the low volume threshold, and 23 clinicians are below. So this scenario is fairly straightforward, but they do have two reporting options. Option 1 would be to file 22 individual reports. Option 2 would be to include all 45 eligible clinician types in the group report. And organizations sometimes, especially the larger organizations, struggle with the decision of whether to do individual or group reporting, and sometimes it comes down to a cost-benefit analysis to determine whether the cost of filing individual reports and the work involved is worth it compared to what their score would be as a group. So just, the group reporting, obviously I've said this many times, but I think it's important. The group report must include all eligible clinicians. And in this scenario, if you did want to do a group report and you had a couple of really high performers in this group, you may choose to do a group report plus maybe a couple individual reports on your high performers so they could get the higher of the two scores. So at this point, I'm going to we'll pause for a minute and see if there are any questions. And Jennifer, could you remind people how to ask a question if they have one?
We will now begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. There will be a delay before the first question is announced. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone.
Notice on the one slide, you did say that only eligible clinicians that exceed the low volume threshold
We have
will
a
be
question
eligible
from
for the...
Leah.
Okay. Leah, go ahead.
Hi, I'm from the Bemidji area Indian Health Services, and I have a question. On one of your slides, you did state that only eligible clinicians that exceed low volume threshold will be eligible for payment adjustments, but I thought they stated it's everyone that reports in the group gets the payment adjustment.
The MIPS score is assigned at the group level, but the only ones who receive a payment adjustment, and I'll ask if there's anybody else on from Lake Superior Quinn that can substantiate that, but we kind of had this discussion just before the presentation. Only those that exceed the low volume threshold would receive a payment adjustment.
Okay. Yeah, this is Reed Harper with Stratus Health, and I'll underscore that. That is indeed true. If you're individual eligible and exceed those thresholds, then you would be receiving the payment adjustment within a group. But those who are not eligible within a group do not receive the payment adjustment.
So if I have a site that's adamant about reporting as a group, say let's say for a group of 12, and out of that 12, they've only got 2 required eligible clinicians that do exceed the low volume threshold, only those 2 eligible clinicians is going to receive the positive or negative payment adjustment. They're assuming it's going to go to the whole group, and the other 10 clinicians that aren't actually eligible are going to benefit from the payment adjustment.
Yeah, and that's not true. However,
Okay.
the advantage of doing the group report would be, let's say those that do not exceed the low volume threshold are really great performers, and they would raise the score for your clinicians that do exceed. Then a group report may be beneficial in your case.
Okay. Thank you. I got to run, but just can I get a copy of these slides, Lori? This is Leah Tristagay from iShift.
Sure, Leah, Teresa, I'd be happy to make sure that you receive them.
Thank you.
Okay. Are there any other questions?
We have no further questions at this time.
Then I'll check with Lori. Anything in the Q&A or chat?
Yes, there is, Mona. There was a question asked in the Q&A. Is CMS going to continue to send eligibility letters so we know what providers are required to report? How does it work if there are non-eligible for the first letter but eligible for the second letter?
That's a really good question, and that's kind of speaking to the fact that there's two different measurement periods. The current lookup tool on the CMS website is based on September 1st, 2015 to August 31st, 2016. And then there is a measurement period for the following year, which we have not seen. But it's important to note that that second measurement period will not include new clinicians. It will not make clinicians eligible. It will only be done to exclude additional clinicians. So, for example, if you are eligible in the first measurement period, you meet the eligibility criteria, you meet the low volume threshold in the first measurement period, but do not in the second measurement period, you would be excluded. But on the other side of that, if you are excluded in the first measurement period, you cannot become included in the second measurement period. And I hope that answers the question. Okay. Any other questions in chat or Q&A?
Yes, there is another question in the chat. If the provider is in a Track 2 ACO, which do they have to submit, APM or MIPS?
Repeat that again, Lori. I'm not sure if I understood that.
Yeah, and it is in chat as well if you want to read it. If the provider is in a Track 2 ACO, which do they have to submit, APM or MIPS?
If they are in the Track 2 ACO and they meet the qualifications as a qualified participant in that ACO, and I put the link to check to see if they're a qualified participant, they would need to report through the ACO. If they are not a qualified participant, they would need to report to MIPS. Any other questions?
Yes, there's another one in chat. If we have no providers eligible to report, is there any reason for them to report anyway? In parentheses, individual reporting, or would that even be possible?
They can report, they can do a group report, or I suppose they could do individual reports as well. And the only reason you would do that is to receive feedback for planning for future years when the clinicians may be eligible to report. There would be no payment adjustment. That was a good question, too.
And Mona, there's another question in chat as well, and it says back to eligibility. How soon will the provider tool be updated for 2018?
The provider eligibility, I do not know that answer. Reed, do you have any insight on that?
No, unfortunately, I don't have any dates, or I haven't seen any material that mentions a date for the update.
Okay. All right. Any others?
And we have a question from Doug Roselle.
Okay. Go ahead.
Yeah, hi, Doug Roselle from Healthy. You had briefly mentioned a second ago about checking if a provider is a QP for an ACO. Is there a link for that somewhere?
There is, and it was on a previous slide, and we'll get that into the chat. I don't know, Lori, if you captured that, if you want to.
Yes.
Okay,
I do have that in the chat as well, and I double checked it, and my link is working. It's data.cms.gov and then /QP lookup, and that can be done by NPI.
Thank you.
Any other questions?
We have no further questions on the phone.
Okay. With that, I'm going to turn it over to Reed. Reed, do you want me to? I can pass the slide control to you, or I can just advance your slides for you. What would you like?
Let's try and pass the control over and see how that works, and we'll
All right.
fall
I'll
back
see if
and
I
have
can
you
do that.
advance them if we have any difficulties.
All right. You should have control.
Okay.
It's coming over.
Well, I think we're going to continue the conversation on the topic of audits and audit readiness, and I'm going to give you a little historical overview from the perspective of meaningful use, which kind of predates, the advancing care information category and really kind of sets the stage for what we'll likely experience under the MIPS program. And we don't know a whole lot. There has been some information that's been passed along by CMS, and I'll talk about that. But what we can do is talk about what we know from meaningful use, knowing that there will be definitely some similarities in preparing for an audit and also for data validation. And I'll talk about those terms, what is data validation, what is audit under the MIPS program. So we'll look at what CMS has put out there so far. And also we have created a tool here at LSQIN, Lake Superior Quality Innovation Network, and we have put that together in Excel, and I'll talk about that as well. So first of all, we'll want to take a little walk back in history here to meaningful use, and we know that under that program, there were a lot of incentives paid out, really billions of dollars, and we know that audits did indeed happen under that program. And while we were under the meaningful use program, there was a 1 in 10 chance of being audited. What will that be under MIPS and the new categories? That remains to be seen. But CMS did share some information, so I think as we go forward and we get into 2018, and when we do our submissions, I think we'll hear a little bit more about that because there is indeed requirements, and I'll talk about those for MIPS and what CMS has said about them. So the auditors did indeed retract incentive funds on behalf of CMS when program participants failed an audit. So it wasn't just the fact that you didn't perform well and they gave you a second chance. They actually did retract some payments. So that's one of the things we want to kind of keep an eye on. Will that be true under MIPS as well? If indeed an organization did fail an audit or they were flagged for the audit, one of the primary reasons was that there was a poorly done or actually no security risk assessment done whatsoever for that protect patient health information objective. And so how does that translate into MIPS? Well, under the advancing care information category, the evolution of meaningful use, we have that same objective in the core 4 or 5, depending on whether you use 2014 or 2015 certified EHR technology. We have that same objective there. And it's an easy one because it's yes, no, and we can say, yes, certainly we did that, but that is something that they really take a look at. And if you say, yes, we did that, and you have an audit, and they found out that you don't have a plan in place or this wasn't done to mitigate those items that you identified, then you would indeed fail that audit. So the next bullet point there mentions big risks, simply just not being prepared for an audit. One of the challenges under meaningful use was that people knew that these were coming, but just didn't have the materials assembled and weren't able to respond within, as you see in that last bullet point there, a 2-week time frame, and I think it might have been even tighter. They might have loosened it up a little bit, but I think it was about 10 days or so, 10 business days, so roughly 2 weeks calendar time frame. So also, what's true under the MIPS audit program is that there will be a 6-year retention period, so all those materials that we're retaining want to do the same thing that we did under meaningful use. The audits were actually outsourced to a company called Figliosi & Company, a law firm out of D.C., and it remains to be seen what CMS will do. In all likelihood, they'll probably outsource that again. It's best to have a third party doing an audit, so there's no bias there, but no announcement to that effect yet. And then the following 2 slides are just excerpts from the CMS Guidance under the Meaningful Use Program, and we'll see a similar fact sheet, and I'll reference that in a few slides here. But it just kind of gave you an overview, what do you need to pay attention to in audits, and I just wanted to reflect on this in this slide here. Under meaningful use, they call it a pre- and post-payment audit. And here we're going to have different terminology in this called data validation and simply audits. So that kind of is equivalent to the pre-payment audit and then the post-payment audit. So why is this a concern? I know we find ourselves in the context, here we are in year 1 of MIPS, and we're trying to comply with the program, figure out what quality measures we want to report on, and what we want to do as far as choosing ACI and any performance measure and figure out improvement activities. Why should we worry about audits at this point? Well, the context is back in June, July timeframe this year that the Office of Inspector General came out and did a report on the Meaningful Use Program and found out that about $730 million was inappropriately paid or missed payments were made. And so they kind of highlighted that fact. And that got the attention of a few senators, and there were some hearings and conversation around that. So about July 12th, as you see on this slide, there was 2 senators, Hatch and Grassley, and they had a letter that was sent to CMS, and one of the quotes was there, if CMS is capable of recovering taxpayer money that should not have been spent, the agency should take all reasonable steps to do so. And this is a little kind of copy and paste from that letter. And I just wanted to read you one of the bullet points that they had inserted there. And they were asking CMS to describe how targeted risk audits will work to recover inappropriate payments already made and prevent inappropriate payments made in the future, including the context of the Medicare merit-based incentive payment system that pertains to EPs, well, now they're ECs, eligible clinicians, beginning in 2017. So basically, the stage has been set for audits. So we know it's coming, and we know that we have these 3 categories here. And I also wanted to, there's a little update. This is kind of hot off the press there. There's some detail under these colored icons here that says there's no guidance yet on the quality category or advancing care information. Indeed, there is now, and that's incorporated in CMS's audit readiness and data validation tools, as well as the one that Lake Superior Quinn is providing. But just being aware that these are the 3 categories that we're reporting on, and we need to be prepared for an audit and retain some materials regarding those 3 categories. So what can you do? You can go out to this link here, and CMS has provided a zipped file which contains basically about, 4 PDFs and 1 Excel spreadsheet. The Excel spreadsheet contains those quality, improvement activity, and advancing care information categories. And then the PDFs are basically those same Excel spreadsheets, but just in a PDF format in case you don't have Excel and you just have an Adobe Acrobat viewer. You can see those easily, along with that single PDF, which is the fact sheet, which you see just a little screenshot of here, which is entitled 2017 MIPS Data Validation. And basically it states in the fact sheet here that we see that same 6-year retention period. There's encouragement to save those a number of additional years, up to 10 years. There's no reason we can't do that, especially if they're just sitting there in an electronic format. It doesn't hurt to save them a little bit longer. But the data validation audit fact sheet does mention, and there's a quote from it I wanted to share with you, which is under MIPS, CMS will conduct an annual data validation and audit process. So there it is. They have indicated that will move forward. If selected for a data validation or audit, you will have 45 calendar days to complete data sharing as requested. So that's the good news. There's a little bit more latitude and time frame to respond to those audits, and that was one of the gotchas, especially if people weren't thinking about audits under meaningful use. Like I said, a number of people kind of got caught off guard, not expecting to have an audit, but if you fall into that category and just aren't quite ready for it, you'll have a little bit more time to assemble materials. But of course, we want to encourage you to go through these materials, whether it's that CMS zip file or the Lake Superior Quinn Excel tool, and look at what do I need to retain and what do I need to save in the eventuality of an audit so that I'm prepared and can turn this around pretty quickly. So in this slide here, this is just a quick snippet again, a little screenshot of what you see in the first tab. There's some general guidance in the tool, and there's multiple tabs. One is, again, this introduction. There's the general guidance tab. Then there's screenshot guidance. And those items, just like under meaningful use, where you tested yes or no to them, there wasn't really numerator denominator. Those especially you want to make sure that you have screenshots for. And the screenshot guidance in this tab from Lake Superior Quinn also gives you some information about the frequency, where you want to make sure is included in there so that they can see that there's a vendor logo, a date, timestamp, etc. So those are all good kind of concepts to keep in mind to retain for the screenshot. This slide here shows this a little bit more detail. It gives an example under the general guidance of what sort of file folder hierarchy you might wish to construct to retain those materials according to the NPI, and then breaking it down by category. Also could vary a little bit if you were doing group reporting. But in each of those tabs, for whether it's the quality or improvement activity or ACI category, each of those tabs within our Lake Superior Quinn tool, basically those were taken directly from the CMS Excel tool, verbatim, no modifications, and pasted in there just so that you'd have the same information as if you went to the CMS tool. But what you would do is basically look at how are you reporting, which quality measures have you chosen, which improvement activities, which objectives and measures in the ACI category, and then simply go down through the spreadsheet to the appropriate rows in there, and then go across and look at the documentation that is recommended by CMS to retain for each of those. So that's kind of the basics, nothing terribly mysterious. And as far as the audit readiness files go, basically the best approach is to retain this in electronic format because under the prior audit program under meaningful use, they had a secure web portal, and it made for a very quick and easy turnaround if you had those already in electronic format in a nice structured file folder hierarchy, just to pull those up, upload them to the website, and you've taken care of your due diligence and response in getting back to CMS, or in that case it was Figlio's company, we'll see who it is in the future, but you're kind of set and ready to go. Again, we know that in the MIPS program, we're organized at the TIN level, so that might be a good organizing principle for your file folders. And then, again, like I mentioned, based upon whether you're doing individual or group, you can determine how to organize it accordingly. And you want to, of course, also last bullet point there, just kind of keep this on a year-by-year basis so that down the road there's no necessary time frame that those audits wouldn't happen. And so basically, what's the look back period? If I'm being, if I have an adjustment, let's say in 2019, can they only look back at 2017 performance period? But let's say we're now like 3 or 4 years into the program. Could they go back and say, like, we want to see something from your 2017 performance period? I know under meaningful use, there weren't limitations like that. So in all likelihood, you'd want to make sure you've got those retained for each of your performance periods. Again, that 6-year retention period. This slide here just has the links that you'll need if you wanted to go directly to that CMS web link and download the zip file with those PDF and Excel files. There's that link there. The second bullet point here is most of the material that I just shared with you, I've assembled in a 13-minute, you'll hear my voice with a narrative and voiceover, and that's out on our Lake Superior Quinn site, and just kind of repackages the same material a little bit more in depth, but gives you the same overview in a recorded webinar. And then lastly, there's our Excel tool, so you can get that as well. So I've kind of rattled right through there in the interest of time. I wanted to leave a little time for Q&A, and also if you want to jump back and ask questions about Mona's section of the presentation, we can certainly do that as well. So let's open it up for Q&A here.
If you have a question, please press star then 1 on your touch-tone phone.
And you can also put your questions into chat or the Q&A section on the webinar.
And Reed, this is Lori, just for the audience to know that I did put those 3 links also in the chat.
Okay, very good. Appreciate you doing that.
And there are no new questions in the chat at this time.
There are a few questions in chat about the slides being available. They should have been available prior to the presentation when you logged in. Otherwise, they will be posted, I think, on the Lake Superior Quality Innovation Network. I don't know if which slide, if people are seeing the contact for each state, that slide, or if we, Reed, I think you still have control if we need to advance that. Not sure.
I certainly do.
So if you do not get a link to these slides, these are your contact people in each state, and if you want a copy of the slides, just reach out to any of us in the states. And if you want to go to the next slide, Reed, I think you're still, and so I think the next slide. So if there are no further questions, again, we've got a few minutes if there are any more questions.
Sure, we'll just wait a minute longer here, but we'll certainly wrap up early if there's no questions. But I think the big takeaway is just to kind of get this on your radar, a couple of things that Mona went through, the scenarios that there are different options for reporting and different strategies that you can really take, whether to report as a group or divide up as individuals, and there are many nuances to that. So again, refresh your memory from Mona's section of the presentation, looking at, does my organization pertain to one of those scenarios? And we're certainly here to walk through with your particular organization and figure out what your best approach is. So contact our help desk according to that slide there. And for my portion of the presentation, I was just going to mention, I wanted to get this on your radar. It really hasn't been talked about much, but under meaningful use, I can assure you this was one of the gotchas when people came out, or I shouldn't say people came out, when the auditors came later and were requesting these materials. There were quite a bit of kind of hurry up and scramble and assemble material type scenarios. So we just wanted to get that in front of you and have you start thinking about that.
And the other thing that I would remind people for reporting options, those of you who are part of an advanced APM or qualified participants in advanced APM, I didn't go into it in great detail, but the ACI category does require some reporting through MIPS for these individuals. And I would encourage you to maybe reach out to your the person, your contact for the state, and we can help you through that. If there are
any questions, I just wanted to thank everybody for their time. And Mona, any closing comments on your part?
No, we would thank you for taking the time to join us today. Just know that your contact people from the Lake Superior Quinn are here to assist, and feel free to reach out to us at any time with your questions, and we'll give you a hand. And with that, we'll say goodbye. I think we have a open office hours that's scheduled for next week.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You